Welcome, Kevin. Tell us a little bit about yourself and what you do.
Shahid, great to see you again. My name is Kevin Mahoney, and I have the privilege and honor of being the CEO of the University of Pennsylvania Health System, which is part of Penn Medicine, a truly integrated academic medical center.
No, that's great. And you guys are doing some really great work. And we wanted to jump really into this new thing that you guys, you have you're leading a public-private coalition to help basically local safety net hospitals in West Philadelphia. Why do local safety net hospitals need help at all? Aren't they supposed to be a safety net that the government will help take care of? Why do they need you guys to jump in a public-private coalition?
So, Shahid, we jumped into Old Misericordia Hospital, which is about 20 blocks west of the campus here in West Philadelphia. It is referred to as a safety net hospital, just like Hahnemann and other hospitals. And safety net hospitals, I think the objective we had was not to mourn the loss of the bricks and mortar, not to mourn the loss of healthcare hospital, but rather mourn the loss of access to ambulatory care, because as the world shifts more ambulatory, more virtual, why should a resident of West Philadelphia have to get on 2 buses to get to the physician's office? Why should a resident of West Philly have to travel 2 miles to see a doctor? So we wanted to flip upside down the idea that we're saving a hospital. Rather, we're creating a healthy village concept, a campus that'll provide primary care, ambulatory care. It still has an emergency room for people that need it, but it also has nutrition courses. It's going to have how to find a job, how to function. Interestingly, in the virtual world, we also want to make sure that we have rooms where people could go in and do a telehealth visit. Because we're used to, I'm used to, if I want to see my doctor, I can go into the den and call them. My family knows to stay out. If you're in a house that has 3 generations and 1 computer, it's pretty hard when the teenager wants to do his homework and you're trying to do a telemedicine visit on the same computer. So part of our idea was, even in the virtual world, having a spot on the healthy campus where you could go in, a room, set up, computer, printer, everything you need, and be able to provide better access, get through some of that digital divide issues that we've seen in virtual health.
Yeah, I know what I love about this particular initiative of yours is you're really trying to move away from pure sick care into proper health care. And healthcare begins with access to care, access to education, beginning from places where not everybody already has that capability. So to me, this seems like this is a true innovation in the sense that you're trying to think about where do people need the care before they actually become sick, right? So that everybody has wanted that for many, many years. But every time we think about this, the very first thing we think about is, oh, why don't we give them SMS? Oh, maybe just give them an app. And we somehow believe that giving an app to somebody is actually truly going to make them healthier. And that's not quite the case, right? You need proper structured healthcare education, whether that's through school or other means. But as soon as you tell people what they need access, right? And then this problem of wealthy people having access is never an issue. But for a regular person, having access has always been an issue. And do you feel that that is really where you're trying to innovate this, that access itself is the innovation?
I think innovation starts with access, just as you said, giving people an app, giving them access to a digital interface. It seems like that's enough, but it's just a start. And so access, I think, is the entry point. But as my colleagues on the medical staff tell me all the time, Kevin, you got to get upstream. If you want to treat diabetes, you got to get to the food deserts. If you want to get people out walking, you have to have safe streets. So get upstream from the problem. Don't treat the problem. Don't treat the symptom, rather, but get upstream and really try to address. So an example that we've put in, although not IT related, but we have a large greening initiative in West Philadelphia, where we are taking vacant lots and other spaces and reestablishing the tree canopy, because there is scientific evidence that people feel calmer, more at ease when they're within nature. And also, if we can bring down some of the heat island that the urban centers are developing. So Penn, we're not just healthcare. It's how do we solve the whole problem. IT is going to be a big part of it, but it's not the only part.
Yeah, I love that. Especially as a healthcare IT guy myself, we often think about technology as solving a problem, which in many cases it does. But I get the feeling these days we're not even quite sure what the problem is, but we're going to solve it with IT, right? How does that work? And I think this is what your colleagues are telling you with respect to swimming upstream. In the business model world, we call this vertical integration, right? Make sure that a company like Apple, which literally controls the chip all the way to the end experience, can really give a much better experience overall. And we in healthcare forget the enormous amount of fragmentation, the intermediation that people go through, and that's on the wealthy side, right? Like if you're wealthy, you go through intermediation and fragmentation, then you can hire people and take those out. But let's look at these, just normal communities, not even the impoverished one, just like normal communities where not everybody can afford that. Access is your first problem, through the education side. But what are some of the other challenges that you're seeing in virtual care? Like you mentioned, 3 generations in one house, that's one problem. How are you looking at other problems so that then maybe our innovation partners in the community, the Googles of the world, the Microsofts of the world, et cetera, can come in and say, okay, that I have a solution for. But do you agree that maybe we're not defining the problems well enough at the moment?
Yeah, so I think the biggest challenge we have in virtual care, whatever you want to call it, digital health, virtual care, telemedicine, everyone keeps telling me people are going to come in and they're going to take all your business because they'll be able to do it on an app, they'll be able to do it telemedicine. The truth is you need coordinated care. And it's going to be a combination. It's a hybrid of both physical in-person care and virtual care. And one's not superseding to the other. They need to coexist. But the trick in all medicine is to make sure you have that quarterback, that primary care doctor who's looking after you mentioned Apple and their vertical integration. Very similar. If you're in the hospital, who's making sure you're getting the right home care? If you're at the home, who's making sure that your neighbor's checking up on you? All these things have to be coordinated so the tests aren't repeated, so that tests are followed up on. And virtual is going to be critical to our future, but it's another site of delivery in a coordinated care pattern.
Yeah, so let's expand a little bit on that, challenges around care coordination, and not look at the folks that are well off because they can afford other ways. What does a normal person do today to help with care coordination where the wealthy might be able to hire a patient advocate or something like that? What do you think that the hospital that are thinking very community oriented could help with proper care coordination without affording a patient advocate that you can go hire separately?
Yeah. So I think a very simple place for us to start is we use an electronic medical record that is great at dropping bills. It's great at documenting. It's a pretty lousy for a patient to interface with. And it's hard to change the EMR because it's so rules-based upon CMS rules, Joint Commission rules, Department of Health rules. I see us taking that backbone of an EMR and surrounding it with API-like apps that'll make it much easier for the patient to interact with their healthcare system. So that just like Google or Amazon, when you order, everyone says I can fly around the world without ever talking to a human. But when I go to the hospital, I got to fill out the same form 12 times. We can make improvements rapidly and make it easier for people to get the information and to be a true partner in their delivery of care. But I think it's going to come not from a reliance on the current EMR system, but on Penn, Intermountain, Mayo Clinic, others developing apps and sharing those apps that surround the EMR and make it easier for a patient to actively participate in their care delivery.
Yeah, that's music to my ears. I mean, this is where I think as you look at this and, there's one business model that says vertical integration, you guys can help really a lot with deconstructing what it takes to do care coordination, systematizing what you can do within your organizations, and then say, look, we're going to let you connect in and do the other myriad hundreds of things that you possibly cannot do as a single organization. And so just like the Amazons of the world, et cetera, could do a whole bunch of things, but they allow APIs to come in and enhance capabilities because they're already maintaining and managing the shopper, as it were, and then other people add to it. Is that the kind of situation you're thinking is where third parties could help augment what you're doing by connecting to your system of record with your systems of engagement with enough APIs for the things that you don't necessarily have either the time or the inclination to do, because there's other stuff that you're going to be good at? Where are you in that journey of kind of like deconstructing these and getting these systems out to where people can start connecting with them?
Sure. So it's a wonderful question. And I say this all the time. I will partner with anybody that is willing. I understand capitalism, people want to make money. Anybody that wants to keep the patient at the center of care, I'm willing to partner with. If they make some money, in addition to that, I'm okay with that. But first, it has to be, is the patient care being improved? I think if we build on the Amazon example and where I might apply that to healthcare, I go on Amazon, I order, they say you want same day shipping, 2-day shipping, you'll get it a year from now shipping, and there's prices that go with that. I place the order and it's a FedEx that's delivering it. I then get a FedEx tracking number. I don't have to go to a separate website and different things. Like immediately I'm connected to FedEx and I'm able to follow that shipping. So it's seamless to the consumer in that example. In healthcare, diabetes management is something we talk about all the time. Following people's blood sugars, using artificial intelligence to follow an algorithm to make sure that we're intervening when we need to. There's a company out there, Livongo, who has already developed that. There's no reason for Penn to develop its own, but I don't want the patient to have to, well, I got to get in this app to do this, and then I got to download it and put it into the HUP EMR. We need as an industry, need to have more of that interoperability between third-party apps and the basic backbone of the hospital EMR.
Yeah, I mean, when I started my healthcare IT career in the late 90s, it would be hard pressed for me to say that I could predict that the CEO of a very large hospital would spend their time talking about innovation through APIs. I mean, just this conversation is so enlightening, because there are things that especially when you start deconstructing, that you can do. Now, one thing that we can start thinking about is, we've heard a lot this year, especially over the last 14, 15 months during COVID, about equity, diversity, more inclusive environments. There's a lot of baloney that we can talk about at the highest levels. But when you as a CEO are actually talking about things like APIs, et cetera, that allows a third party to actually come in and enhance services for all of your patients, which are of different races, colors, creeds, et cetera. Do you feel that innovation strategy will take you beyond talk? I mean, obviously everybody wants inclusion, everybody wants diversity, everybody wants health equity, but you can't pull that off with talk only. So do you feel that this is a way that you're going to pull that off, or is there other things you're doing around the inclusion, diversity related topics?
No, I think first we'll build on the API, and then we'll expand from that a little bit. But clearly, Penn Medicine's biggest impact to a more inclusive and diverse culture, a more just culture, is to close the gap on health equity. And we need to do a better job. So this year, we included in 688 of our top managers' pay 2 goals. One was that we would reduce maternal morbidity and mortality in Black women, and that we would increase a number of colorectal cancer screening in our Black population. And we have done a fantastic job with the first one. We're using something called Heart Safe Motherhood. It is an app, monitors blood pressure, follows people through the course of their pregnancy. And there's a lot of tricks to it that we could talk about, but it is an app that is your friend and helps manage your care and coordinate it going through. On the other end, if we go to colorectal screening, we kept calling everybody. Pandemic had a second wave. People didn't want to come in. We're trying to put a big push forward. And we said, let's mail to 3,000 people the Cologuard test that you see on TV all the time. But you heard my use of the word mail. That that is a hit or miss of unforeseen proportions. And whether or not those will actually get to our patients, it's a real question. So a digital connection, text-based, that people are used to using, that is something that we need to concentrate on, because the old-fashioned way, in so many cases, is just not going to work. And as we move towards, again, a more inclusive environment, as we try to close the gaps in health equity, technology is going to help us shrink that very, very rapidly. On the other side of a more just and inclusive culture, so many of our employees, with schools being closed, with daycare being closed, they have to use a lot of their flex time to take care of their kids. Isn't it great that you can go into a department meeting by Zoom? You don't have to drive down to the main campus. You can stay at home, you can multitask, you can still participate in a department meeting, which is critical to you getting promoted on the faculty. But you're able to do it in an environment that allows you to do the other things in life that are required. So I think it's going to allow people to expand, through the multimedia channels that we're using, expand their connections, and those connections lead to promotions. They lead to more intrinsic value in your career. And I think it's going to be, we're going to look back on the pandemic, and it's going to be one thing that we said that was a great outcome was the use of the multimedia platforms.
No, I love it. And in fact, one of the things that caught my ear, Kevin, in this case was that you can do things for health equity and accessibility and inclusion by measuring that things are getting better. That's the one thing that I think we as leaders, and I'd love to get your opinion on how you would, give some advice to leaders to make sure that they're getting things done by focusing maybe on things that you can prove. Like at the beginning of the year, you have metrics A, B, and C, KPIs, X, Y, and Z. We have a lot of talk about inclusion and equity, et cetera, but we don't put KPIs against them. And that's what I got here is that you actually have real KPIs that you can say, look, I know how many elderly Black women are suffering with ABC. At the end of the year, if we don't see that number change, all of this is BS, right? We're talking about health equity, this and that, but there's no numbers that show things are improving. So so just in the last couple of minutes that we have here, tell us a little bit more about how leaders really can stand up and do things that only they can do beyond talk, that maybe their staff can't do for them, right? What do leaders have to truly lead with here as far as equity and inclusion are concerned?
So to budget is to choose. And as leaders, we can choose where we're putting our budget. And I can put it into the new hospital right behind my right shoulder. I can put it into more IT systems. I can put it into raises. If we want a more just culture, we're going to have to budget money, and not a little bit of money, but a large amount of money to move the needle and to truly say, this is critical, this is important. And the best way for a leader to do that is to put money behind it. And that's all within our ability each year to make that decision. It's hard because you're taking money away from other initiatives you want to do. But it's just talk if you're not putting the resources behind it.
No, I love that. And as an engineer, my normal rule is if I can't measure it and I can't see it changing, it's all talk, right? That's perfect, right? That's great advice to say, look, I know that last year you had no budget against it, but this year I saw that you had 3% of your budget against that task. That means you were doing something with it. That's just fantastic advice. And as an engineer, I love it because it's something that we can measure going up or down there. With that was awesome. Great to see that Penn Medicine isn't really just looking, primarily at the safety net hospitals and things like that as a do-gooder charity thing on the side. No, it's for real, actual change in the community by providing access, getting vertical integration done. And then I love the idea of deconstructing, getting the APIs connected, and being able to allow third parties to maybe enhance your patient's experience. That's awesome. Anything else you want to add before?
No, just the last thing I would toss out, a number of our faculty started what we call the BOLD solution, which is how can, again, after the death of George Floyd, how can Penn Medicine lead towards a more just culture? And it can't do it alone. So we've reached out to Independence Blue Cross, the Thomas Jefferson University, Temple, the public health, the Philadelphia Public Health Department. We're trying to get everyone around the table pulling in the same direction. So rather than us, everybody doing a little bit, is there a way for us to do a lot together and make one bold move? So an audacious goal: eliminate maternal mortality by 2025, and do that as a city, not as an individual hospital. And again, I think that's leadership, which is not just that we want credit, we want the whole community to benefit from our leadership.
That is so awesome. So we'll have to interview you on a regular basis and see how you're getting as a city towards that goal, which is fantastic. So with that, I want to thank everybody for listening. We'll have Kevin on in the future as well.